Hello, KMC University clients. My name is Dr. Richard Mason, and today this help desk episode is going to go over how to properly diagnose and document the different types of headaches that we see on a day-to-day basis in a chiropractic office. So there are three primary headaches that we're going to see in chiropractic. Number one is the tension headache. Number two is a migraine headache. And number three is a cluster headache, which is more rare. We often will also see a common secondary headache, which is a cervicogenic headache. This type of headache is seen more commonly than a cluster headache. So let's dive into the primary headaches that we're going to see. The first one is going to be a tension headache. The code for a tension headache is G44.209, and that is a tension headache that is not intractable. And this is a key point because you don't want to put, unless it's clinically relevant, you don't want to put an intractable headache because that's usually an emergency. A non-intractable headache is one that is episodic and comes and goes. So you want to make sure you get that part of the diagnosis correctly. The second most common primary headache is a migraine headache, but that can come in two different forms. The first form is a migraine with aura, and then there's without aura. So it is critical in your documentation when you're doing the history to elicit out if a patient truly has aura symptoms or they don't. And don't put the wrong diagnosis in if they don't have aura symptoms or vice versa. And then the last, more rare form of primary headache is cluster headaches. And these you won't see very often. Neurologists see these more than the typical chiropractor. So when you are listening to the patient and they're describing their headache, tension headaches are usually bilateral. There's a pressure, there's an ache. It may kind of throb, but it's typically, it gets better with medication, it gets better with chiropractic adjustments, gets better with rest. Migraine headaches, on the other hand, are usually on one side, and it is more throbbing and pulsatile and sharp, and it interferes with daily function. When someone has a migraine, they're not able to finish their day. And they can have light sensitivity and they can have sound sensitivity. And that's unique because tension headache sufferers will have one or the other, but not both at the same time. The other thing that's different than migraines is patients can have nausea. They can have vertigo. They can have ringing of the ears. They can have blurred vision. And those are things that normally don't happen with tension headaches. Cluster headaches are a little different as well. And instead of being on one side like a migraine, they're right over the eye, and the patient has attacks that can go 1 to 8 times per day, and it's a sharp attack, and then it can quit, and then they won't have an attack for a few hours, but that can go on for days. So tension headaches normally last 3 hours to 7 days, but there's usually a period where they are absent. Migraine headaches can go 4 to 72 hours, and most of the time with migraine headaches, they are severe, and a patient just has to find a dark place and without sound, without light, and they just have to let it pass. Now, if we get to the objective findings that need to be in your SOAP notes, objectively, tension headaches have a lot of muscle and joint tension, but it's diffused throughout the neck. Migraine headaches, on the other hand, there is a lot of upper cervical restriction and tenderness, especially in the suboccipital region, but it's on one side. And the objective findings to look for a cluster headache are going to be sympathetic signs, which are going to be redness in the eye, tearing of the eye, or a droopiness of the eye, which definitely makes that different than the other two primary headaches. So let's finally talk about secondary headaches. Cervicogenic is one that I talked about that you're going to see, but sometimes patients will come in with headaches that are not the primary form, but they're indicating that something else is going on, and they're what I call my red flag headaches. So some examples of that would be a cervical arterial dissection. It could be a stroke or a transient ischemic attack. It could be a subarachnoid hemorrhage with a thunderclap headache, or it could be an intracranial mass or a headache, or an infection. Those are headaches that you need to pay attention to when they walk in. So they're all going to present much differently. They're going to be neurologic signs, they're going to be more severe, and then the patient is usually in pretty dire straits when that type of headache comes in. But chiropractors need to be aware of those. So let's take cervical arterial dissection as an example. That usually presents as a unilateral headache with head or neck pain that is about 3 to 7 days of onset that is not being responsive to medication or rest. So if a patient comes in, you need to ask probing questions about, tell me when the neck pain started. Does anything help it? Does medication help it? Has the headache gone away at all in 3 to 7 days? If the answer is no to all of those, that's a referral to the emergency room, and it's some kind of vascular or other pathology headache until proven otherwise. So just don't assume that when someone comes in with head or neck pain that it's the same presentation. Ask some probing questions, and sometimes you'll be surprised what patients tell you. If the headache is severe, you may have to ask the question a couple of different times, different ways, so that you can really get a good answer. So I hope you enjoyed this Help Desk episode. The documentation and the research to support the findings in the Help Desk will be attached to the video. Thank you and have a great day.